Greetings to each and every one in the mighty name of Jesus. Greetings to you all. Thank you all for joining us tonight. Here we're going to have a discussion on the church and the COVID vaccine. We're just having a conversation. It's an informed conversation, just to give you information on the vaccine and what it contains and everything, just putting all conspiracies to rest. This is giving you an opportunity to ask questions. So I'm going to ask you to please use the chat and ask your questions. We do have questions coming in also. So I'm going to ask you to please ask your questions as you've been given this opportunity. Before we go any further, I'm going to read Proverbs 10, verse 13. And it says thus: in the lips of him that hath understanding, wisdom is found, but a rod is for the back of him that is void of understanding. And we say amen to the reading of God's holy word. I'm going to now hand over to our moderator, who is Brother Purcelle. I'm going to ask him to please unmute himself and to take over.
Good evening, everyone, and welcome to this platform. Before we go anywhere further, we just read a small word of prayer so that God will just lead this present platform now. Father, we thank you for bringing us together. We thank you, God, for the power of the word. Father God, everything that we have to do and say, may it be done in order and decency. We thank you for health. We thank you for strength. In Jesus' name we pray. Amen. Okay. The reason why we are gathered together is because of, one, the government is saying that we, the people from the Black and minority ethnic group, has least taken up this vaccination. Many members are approaching the church bishops. Should we take the vaccination? So I, being a member of the health team, have approached the doctors of Swanswell Medical Center, Dr. James, Dr. Steele, Dr. Mangat, and we have agreed to come together, join with the International Firstborn Church of the Living God to make this presentation. Now, as River has said, what is going to happen? We have asked people to send in some questions. We have received about 40 questions today. We will make all attempt to answer those questions. Meanwhile, if you still have any questions, you still can post them on the group chat. We will attempt also to answer them. So we will begin our presentation tonight with Dr. James, who is one of the senior partners of the Swanswell Medical Center. And Dr. James will give you brief history on the statistics, why we, the Black or minority ethnic groups, are not taking up the vaccination. He will try to clear some myths. He will also give the reason why they are vaccine resistant, and will give some brief history. So, Dr. James, the platform is now yours.
Okay, thanks, Purcelle. Can everybody hear me? Can people hear me? Yeah, okay. I'm going to attempt to share my screen. Okay, can people see my screen? Yeah, okay. All right. Thanks, Purcelle. So, as Purcelle said, my name's Spencer James. I'm a doctor at Swanswell Medical Centre. Thank you for all giving up an hour or two of your valuable time this evening to hear what we have to talk to you about. And my presentation really is going to be giving you a little bit of information about me first of all, and my motivation for agreeing to do this talk. I'll also then go on to talk about the impact of COVID-19 on the Black community as well as the wider BAME community. I'll look at some of the socio-economic issues as to why the Black community is disproportionately affected by COVID-19. And I'll also then cover briefly the topic of vaccine hesitancy. So I think this is relevant because I think what I'm trying to do here is share some common experiences and empathise with you guys in terms of your concerns that you may have. I was born and raised in Birmingham. I'm of dual heritage. I'm part Jamaican and part white. I'm a GP, as I've said, and I also have a Pakistani wife. Hence, I'm kind of aware of the wider BAME's concerns as well. And when we were preparing for this talk, myself, Dr. Steele and Dr. Mangat, one of the questions that came up fairly early on was, why is this talk necessary? Given that the Black community has the same access to information as other communities. And that really got me thinking. And what I came up with is that I think there is a lot of kind of mistrust, maybe misconceptions and misunderstandings and concerns about not only COVID-19 but also the vaccine. And I wanted to just kind of state quite clearly from the outset that I think those concerns are legitimate. And I think our job as doctors is not just to give information, but also to acknowledge people's concerns, particularly when people's concerns are coming from a place of legitimacy. So I wanted to make that clear straight from the outset. This talk is as much about hearing your concerns as it is about imparting information. So a little bit about the statistics of COVID-19. There was a recent Public Health England report entitled COVID-19, Understanding the Impact on BAME Communities. And this report acknowledged that COVID is not affecting the population groups equally. It is, as you probably are fully aware, it affects older people disproportionately. Older people are more likely to have severe infection and are much more likely to die from COVID-19. But not only that, it affects men more than women. It affects people living in urban environments much more than those living in rural environments. And most relevant to this talk is that it affects different ethnicities. Black people, Black men are 2 to 3 times more likely than their white counterparts to contract COVID-19, with Black ladies being 2 times more likely to contract COVID-19 than their counterparts. Or put another way, there are 649 cases of COVID-19 per 100,000 head of population in Black men, and 486 cases of COVID-19 per 100,000 population in Black women, compared to around 220 cases of COVID-19 in 100,000 head of population in the white ethnic group. Not only are we more likely to contract COVID-19, but when we do, we're more likely to suffer adverse outcomes. 25% of patients requiring ITU admissions were from Black and Asian ethnic groups. That's fairly stark, given that we only account for about 12 to 14% of the population. Another fairly stark statistic is that whilst accounting for 21% of NHS staff, that's BAME people accounting for 21% of NHS staff, we account for 63% of health and social care deaths. What this slide is attempting to show you is on the top graph, we've got males. On the bottom graph, we've got females. Down the y-axis, we have different ethnicity groups. And this line here is how likely a white person is to die from COVID. The further towards the right of the graph that you get, the more like is the number of times, how many times more likely you are to die from COVID than a white person. And we can see at the top here that black men are pretty much 2 times more likely to die from COVID-19 than a white person, closely followed by Bangladeshi and Pakistani men. And the same is essentially true for black females. They're 1.9 times more likely to die from COVID-19 than their white counterparts. And again, closely followed by Bangladeshi and Pakistani females, who are 1.8 times more likely to die from COVID-19 than their white counterparts. So these statistics, they beg the question, what's going on? We're more likely to get COVID-19, we're more likely to suffer adverse outcomes, and we're more likely to die from COVID-19. At the start of the pandemic, some of you may recall that this disparity was attributed to potential biological or genetic differences between black people, other ethnic minorities, and white people. Research into this area is still ongoing, but I think conclusions are beginning to emerge that actually this difference is not due to biological or genetic differences. Therefore, what else can explain these differences we see? Well, increasingly we think that the differences are explained by greater exposure to COVID-19 in BAME groups. If we take housing, for instance, ethnic minority people are more likely to live in cramped housing. They're more likely to live in multi-generational households. This is relevant because if you are exposed to COVID-19, you then potentially take it back to your family members. If you live with elder relatives, you then pass on the infection to those elder relatives who, by very nature of being elderly, are much more vulnerable to contract severe COVID and ultimately have a bad outcome and death. Also, the work that we do as black people and ethnic minority people tends to be more high-risk jobs. So we are the healthcare workers, the frontline healthcare workers. We are the cleaners. We are the public transport workers. We are the taxi drivers. We are the security guards. All of these roles are frontline facing roles, given greater exposure to COVID and greater potential for infection. And then, of course, when we travel to these high-risk jobs, we're more likely to use public transport than our white counterparts, again, increasing exposure to COVID-19. There are also other issues. There are long-standing health inequalities in black and ethnic minority groups. Some of these inequalities are explained by socioeconomic disadvantages. So there are certain conditions, hypertension, which is high blood pressure, diabetes, cardiovascular disease. These are all well-established conditions which are more prominent in those from economically disadvantaged backgrounds. And then there are also the wider systemic factors, which I'll go into in a little bit more detail later, which also, I think, undoubtedly contribute to the picture that we're seeing emerge. So far, I've only spoke about fairly bleak news. There is obviously some good news on the horizon, and the vaccine forms, the other part of my talk. The vaccine was approved in England in December of last year, and since then, approximately 22 million people have taken up the opportunity to be vaccinated, and we're already starting to see the impact of that on new infections and on mortality rates. that unfortunately is where the good news ends. What this slide is showing, it's a Office of National Statistics slide. What it shows is that 4 in 10, or 40% of Black British adults, report being concerned or would be hesitant in accepting the vaccine. And this is significantly higher than all other ethnic groups. And as you may or may not expect, much higher than in the white population, where vaccine hesitancy is down at around the level of about 5%. The other important thing to say here is that vaccine hesitancy is highest in the younger age group. So Black people under the age of 40 are most likely to express hesitancy in being vaccinated. What this slide is showing you is a comparison between Black people, other ethnic groups, and white people in how likely they are to take up the vaccine. So the graph on the left shows how likely people aged over 80 are to take up the vaccine. The top line here, the dark blue line, is white people, and as you can see, there approximately 85% of people who are offered the vaccine take it up. The light blue line down here at the bottom is Black people over 80, and we're much less likely to take up the vaccine. We're taking up the vaccine in the region of about 60%. The slide over here on the right, the graph on the right, is for the age group 70 to 79, and it's a very similar picture. You can see that white people are much more likely to take up the vaccine. Again, over 80% of people are taking up the vaccine when offered, compared with Black people down at the bottom, we're taking up the vaccine at a rate of about 58%. So what's happening? There are several issues as I see it. As Black people, we're more likely to contract COVID-19. As Black people, we're more likely to suffer with severe disease. As Black people, we're twice as likely to die from COVID-19. And despite all of that, we're less likely to accept vaccination. And why is the big question. And I think this is where I think it's important to legitimize people's concerns, accept people's concerns, and really listen. I show you this slide again, and I circle a fairly important couple of words on this slide. So this slide is the slide that I showed you earlier, showing that Black people are twice as likely to die from COVID-19 as white people. And what I've circled here is this description. It says fully adjusted model. What that means is that when you account for differences in age, differences in socioeconomic factors, differences in comorbidities, so other diseases, Black people are still 2 times more likely to die from COVID-19 than their white counterparts. So what other factors could be explaining this discrepancy? Well, I think historically, and forgive me, but I think this is relevant. Historically, Black people have been subject to fairly shoddy treatment, frankly racist treatment and medical experiments at times. This first man here, he was an eminent gynecologist in the 19th century. His name is J. Marion Sims. This man conducted fairly unethical surgical procedures, experimental surgical procedures on Black enslaved women. And these procedures were largely conducted without use of anesthesia. This image depicts the Tuskegee syphilis trial. This study was a trial conducted in Alabama in the United States, and it ran from 1932 to 1972. And the premise of the trial was to see what the natural history of syphilis was. So that is to say that what would happen to people who contracted syphilis if no treatment was offered. 600 impoverished Black men were recruited to this trial. under the premise that they would receive free medical care. None of these 600 men were aware of their diagnosis of syphilis, nor were they aware that the study of syphilis was the premise of the study. 400 men had a positive diagnosis of syphilis, 200 men were controls. And they were deceived in that they were giving placebo treatments, or they were conned into thinking that research tests were treatments, and ultimately not given a treatment, even when a proven treatment became available in 1947, which is the drug penicillin. Ultimately, 128 of those men went on to die from either syphilis directly or complications of syphilis. Again, a totally unethical study. This lady is called Henrietta Lacks. She was a Black American lady who died of cervical cancer in the 1950s. And she had cervical cells harvested from her prior to death. These cells were subsequently found to be fairly special cells. They were termed immortalized cells in that they didn't die. If treated appropriately in the lab, in the appropriate setting, they didn't die, and they could also be reproduced time and time again. When these cells were discovered to have this characteristic, they were shared widely throughout the scientific community worldwide, as were Henrietta's medical records and information about her family, all without her consent. Again, a totally unethical study. Closer to home and more up to date is this statistic that Black women are 5 times more likely to die in pregnancy or in childbirth than their white counterparts. Absurdly, Black patients are half as likely to receive pain medication in the emergency department as white patients. There seems to be some kind of subconscious belief that Black people don't experience as much pain, perhaps, as white people. And a final statistic, which I would be surprised if people aren't aware of, is that Black Afro-Caribbean males are 6 times more likely to be admitted and detained under the Mental Health Act than the average population. So I show you those slides to acknowledge that there are well-founded reasons for people to have concern. It's not just about vaccines, but about the healthcare system more widely and more broadly. Other reasons for the disparity that we see in COVID-19 rates and also in vaccine uptake amongst Black people, I think are rooted in issues such as structural racism and institutional racism. So this is where you are treated differently, or we are treated differently by institutions such as the education system, institutions such as the police, institutions such as employers, and also healthcare. Also, there is evidence that on a fairly regular basis, Black people feel that when they present their concerns to healthcare professionals, they're not taken seriously, they're ignored, or maybe even dismissed. There's also concerns about the lack of BAME representation in the COVID-19 vaccination trials. And all this leads to an atmosphere and environment of fear and distrust. And I say this to acknowledge these fears and this distrust. This is a fairly wordy slide. I'll give you a few minutes just to read it. But in essence, it's a quote taken from the chief executive of the King's Fund, which is a charitable think tank who conduct research into the healthcare system. And they acknowledge that there is racism, there is inequalities in the society as a whole, but also within the healthcare system. This quote is taken from a recent British Medical Journal editorial, and once again, it's acknowledging and taking on board Black people's concerns regarding systemic issues, systemic racism, previous unethical healthcare treatment, and a lack of representation of Black people in vaccine trials. And despite all of that, I'm still going to end my talk by really imploring people to take the vaccine. I just say again, Black people are disproportionately impacted by COVID-19. We're twice as likely to die. I fully accept people's misgivings about the vaccine. I fully accept that they're legitimate based on personal and also historical experiences. But hopefully by the end of this talk, we will have gone some way to easing those misgivings and allowing you hopefully to feel more confident in having the vaccine. All of us on the panel tonight have had the vaccine. We've also encouraged our family members to have the vaccine, and we've experienced very, very mild side effects. So please take up the vaccine. It really could save your lives. Thank you. And any questions I'd be happy to take.
Thank you, Dr. James, for enlightening us with that history. There were some questions sent in before. If you don't mind, I want to ask you some questions. Is that all right with you?
Yes, sir, please.
Okay. This is a question from Rhonda Bruce. In the trial of the vaccination, was there any representation from the BME group?
Okay, thanks for your question, Rhonda. So we're really using two vaccines in the UK. We're using the Pfizer-BioNTech vaccine, which was developed between an American and a German company. And we're using the Oxford AstraZeneca vaccine, which was a vaccine developed in the UK. And the answer is yes. So if we take the Pfizer-BioNTech vaccine firstly, so this study, this vaccine trial had approximately 43,000 participants. It took place in a number of countries: America, Germany, Turkey, South Africa, Brazil, and Argentina, and there's over 150 clinical sites. And there was BME representation within the participant group. Overall, 5% of participants were from Asian backgrounds. If you take just the US data alone, 6% of patients were from Asian backgrounds. 10% of patients were from Black ethnicity groups, both overall and within the USA. And then there was also representation from Hispanics, making 20% of the overall participant group. The figures aren't quite as good for the Oxford AstraZeneca vaccine. In the UK, only 0.5% of participants were from the black background, but this study also was conducted more widely in South Africa and Brazil, where the representation from Black and ethnic minorities was much better. So in Brazil, 9% of participants were Black, and in South Africa, 70% of participants in the study were Black.
Thank you very much, Dr. James. Rhonda, I hope that answers your question. Following that, Rhonda wants to know, how did people get selected for this trial?
So the trials were what we call randomized control trials. So they would have been advertised and requested that willing participants volunteer, and then on volunteering, patients would have been randomized into two arms: people who either received the vaccine or people who receive something disguised as the vaccine, which is called a placebo, which has no active ingredients. And that's fairly common practice in conducting medical research.
Okay, moving on from Rhonda. We have one from Dora Lyons asking, Black people DNA or immune system are different to other races. Now, earlier in your presentation, you said that we are at higher risk. Is it because of the DNA, the immune system? Can you expand on that, please?
Okay. Yeah, thank you. That's a really good question. So actually that's totally incorrect. And it actually is probably a hangover, a racist hangover from colonial times, when it was felt that Black people were fundamentally different to white people. Even you know, kind of, if we go way back, subhuman and more animal-like than white people. But it has no basis in fact. Black people's DNA, Black people's immune system is not any different to white people's. In fact, I read a book recently called The Book of Humans by an author called Adam Rutherford. He's a geneticist. In that book, that, can you still hear me? I'm having some internet connection issues. Can you still hear me?
Yeah.
Yeah. He made a real powerful statement that the genetic variability in sub-Saharan Africa is greater than that of the rest of the world combined. So you could have an African person in sub-Saharan Africa could have less in common in their DNA than with somebody in the next village, for instance, than you could have in common with a white person, if that makes sense. Did I do a reasonable job of explaining that?
Yeah.
You're as Black people, our DNA is closer to a white person than it could be to an African's DNA to another African.
Okay. Can you repeat the book that you got that information, please?
Yeah. It's called The Book of Humans. And it's by an author called Adam Rutherford.
Mm-hmm. Okay. Dr. James, I think you are frozen.
Hello?
I think what you have to do, you have to write it in the group, because we did not hear that.
Okay.
Yeah, the name of the book.
All right.
Okay. I don't think at this time there are any more questions coming to you. We want to thank you for that presentation. And as questions come in, I might have to refer back to you to ask some more questions. Is that okay?
Okay. Thank you for listening, everyone.
Okay. We now go to Dr. Mangat, who is going to give us a presentation on the COVID disease, the science behind the vaccination, the side effects of the vaccination, and how can we benefit from having the vaccination. Over to you, Dr. Mangat.
Hello, everyone, and thank you for asking me to partake in this very important presentation. I'm just going to try and share my screen as well. Can everyone see that okay?
Yeah.
Okay, fantastic. So as Purcelle said, my name is Dr. Mangat. I'm another partner at Swanswell Medical Centre. I'm also a primary care physician with a specialist interest in post-COVID rehabilitation within the Birmingham and Solihull area. So what is COVID-19? Well, it all stems from what the virus is, and there has been some talk about how, and criticism about how is it one name and then it's another. And that's because the virus is called SARS-CoV-2. And what that stands for is SARS, which is forgotten the term now, significant acute respiratory syndrome, and then COV, which is coronavirus, which is a group of viruses that essentially, when you look at them under a microscope, look like the corona of the sun. And 2, because it follows another significant virus that had an outbreak back in 2003 in Southeast Asia, and that being known as SARS-CoV-1. The disease we talk about is COVID-19. And again, so COV for coronavirus, D for disease, and 19 for when the year when it was isolated. There has been a lot of talk about where it came from, which, to be honest with you, much is wrong. We don't know anything for 100%, but all the evidence points to a Chinese wet market in Wuhan. In terms of its infective period, you are infectious from 48 hours prior to the symptoms starting to up to 14 days post symptoms. And this is one of the primary reasons why it's important to have all these social distancing measures to prevent infection from those that do not have it, do not know they have it, sorry. There has been different reports of mortality, and one of the prime reasons is because there are different techniques in measuring the mortality. And I apologize if I do get technical, but I'll try and explain it as best I can. The 2 main types are the IFR, which is the infection fatality rate, and the CFR, which is the case fatality rate. The IFR is essentially looking at the number of people that have died amongst all infected individuals, including confirmed cases, i.e. those who've had a test, and those undiagnosed cases, the asymptomatic cases, those without symptoms, or those just didn't know they had it, they might have had mild symptoms, or even those unreported cases. And you might ask, how do we know that group? Well, you probably have heard in the news about the Public Health England testing random populations in the country at various times and with a blanket approach just to see who is infected and doesn't know about it. And that's because they're trying to assess various things, including the infection fatality rate. And as you can see here, the IFR is between about 0.15 and 0.2%. And just to compare this against something that a lot of people have tried to compare it against, the flu, which has an IFR of 0.036%. So COVID has a significantly higher mortality. And using the other technique, the CFR, this is the total number of deaths reported divided by the total number of detected cases reported, i.e. you've got symptoms, you've gone to get a test, you've done the test, you're positive, how many of those have then died? Now this has got a higher number and it's the more globally used term. And it has a death rate of 2.2% globally. And that's because, as you can imagine, this group already have more marked symptoms than the other group. They've already got symptoms such that they would go and get tested. So they are going to have a naturally higher death rate. And again, it makes the point more clearer here. And it's probably the reason why it's the more reported term. The death rate is 2.2% against the flu, which is 0.1%, a significantly higher death rate. So nothing to be sniffed at there. Just a brief thing about the risk factors. There are strong and weak risk factors. I'm going to focus on the strong ones today. Spencer, Dr. James has already highlighted the main issue, which is ethnicity. But there's also being male, being over 80, being a resident of a care home, having multiple comorbidities, pregnancy, smoking, and Down syndrome, which is an interesting one, something that was not thought to be a risk factor at the start, but due to constant observation and assessment is now a very high risk factor. Just to highlight what Dr. James said earlier, amongst Black people, the risk is 1.47 times greater than white people of getting the infection. The average age is less than Caucasians. Compared to Caucasians, They're more likely to be admitted to ITU and more likely to need ventilation. The vaccines. So this table shows the vaccines that are used currently within the UK. I'm going to focus on the Pfizer and the AstraZeneca because Moderna, while it has been authorized, hasn't come into circulation as yet. Pfizer, you can see, has an efficacy, which in terms of the effectiveness, essentially, in terms of preventing COVID infection, of 95% compared to AstraZeneca, which has this range that's been widely publicized as between 55 and 82%. The reason for this, however, is more complicated. One factor is that there's two different study designs, and therefore it becomes difficult to compare like for like, because they are not like for like. The other thing is that the efficacy range in AstraZeneca, a lot of it relates to the different time lengths that were used in different groups within the study. Some had 3-week gap and all the way up to 12-week gaps. And this actually was something that developed due to the sites that were used for the AstraZeneca, as Dr. James mentioned, places like Brazil, South Africa, India. And therefore they couldn't always get the vaccines there in that tight time frame. And what they found was that with the 12-week gap, the efficacy was 82.4% at preventing COVID infection. And the cross group against all of them, the average was 70.4%, which is still very effective when you compare that to the annual flu vaccine, which is between 40 and 60% effective. But one of the most important things about the AstraZeneca is that not a single person in the actually vaccinated cohort, that group, was hospitalized, which is really what we're looking for. So it is a very useful vaccine. And that brings me to the next row in this table, where that real world efficacy in the UK, since the vaccine rollout and 22 million people have received at least one vaccine. And as you can see here, Pfizer has an 80% chance of reducing hospital admission, which is that primary goal. While AstraZeneca has been shown to reduce hospital admissions by 94%, 4 weeks after receiving that first dose. And there's also been talk about the variants. We don't have data on everything, as you can see, but we do have some data in terms of the efficacy of AstraZeneca in terms of the UK variant. And as you can see, it's still very high at that reducing infection at 74.6%. Simply by lack of data, we've not been able to have any comments on the South African variant as yet. However, it is good to know that the scientists involved are already creating versions to fight the new variants. Focusing more on the Pfizer-BioNTech vaccine. Now, this is a new type of vaccine, which is 30 years in the making, and it's based upon mRNA, which stands for messenger ribonucleic acid, which is essentially the virus version of DNA. And what they've done is they have isolated the section of the mRNA that codes for what's called the spike protein, highlighted in green here, on the surface of the virus. And this is what allows the virus to bind to cells to infect us, as well as what the antibodies, what our immune system attaches to fight it. And they've isolated that, wrapped it in a kind of a fat lining, and so to allow it to be taken up via an injection into the bodies. Once inside the body, the mRNA vaccine is taken up by the local cells, and they translate that genetic information to present that spike protein. And then that generates an inflammatory response, i.e. activates our immune system to produce antibodies here, these green Y-shaped molecules here, as well as what are called our T killer cells, okay? And they destroy those cells And they basically, you can think of it like you've developed an army now who recognize that particular virus, that particular spike protein, and you are ready now, should you actually ever become infected by the virus proper, you're ready and waiting. It's worth noting that no whole or live virus is involved, and that vaccine cannot cause the disease. And despite it being taken up by local cells, the mRNA naturally degrades after a few days and is gone from the body. And there are no animal products involved in this at all. And it does not contain any preservative. This brings me on to the AstraZeneca one next. Now, this again is another virus years in the making. Sorry, another vaccine years in the making. Okay. And it was actually the Oxford group developed it in response to things like SARS-CoV-1 and MERS-CoV, which is another strong coronavirus that affected Southeast Asia, South Korea in particular. And what they did is they had a plan of what type of vaccine would be useful in any upcoming pandemic. And they decided on a weakened adenovirus, which is another type of virus to the coronavirus, something that's been deactivated and is completely harmless. Okay. And what they did was they took out the genetic code from SARS-CoV-2 and they put it into this weakened, completely inactive adenovirus. And then the same process happens again as for the Pfizer, where it is injected into the body and then the body initiates an inflammatory response, develops that immune system, and is ready to fight should it actually ever be infected by the vaccine, the virus proper. And once again, the adenovirus cannot replicate. So again, no disease. And again, it is destroyed by the body after delivery. And there are no animal products, again, in this vaccine either. There's been a lot of talk about the safety of these vaccines that are in circulation. And I just wanted to show you a couple of slides to show that this is taken very seriously. It's not something that's battered away, and that there's a clear structure in place should any reaction occur or allergic reaction occur. And this is a flowchart provided by the British Society of Allergy and Clinical Immunology. And it's there to manage patients who have a possible allergic reaction to the first dose of the vaccine. And I put it here just to highlight the clear pathway that is available should you have a potentially allergic reaction to the first dose. And as you can see here, it's quite clearly marked out what to do in different scenarios. And I won't bore you with it right now, but if you were to have a reaction, you would be able to talk to your GP and discuss whether it'd be okay for you to have a vaccine for the second dose. And this slide equally is something similar, but this is how you would manage patients with a past history of allergy. And as you can see, it's quite clearly marked out here in this useful traffic light format, where you can see in the red column those that have had a prior systemic allergic reaction, quite a severe whole body reaction to the first vaccine, or a prior allergic reaction to any other RNA-based vaccine, or one of its component parts that are contained within. And therefore, those people are not given the vaccine, and you would be referred to an allergist before any decision about a second dose would be given. And then you go to the other side, where you've got this green column here. And you've got those who've had a previous allergic reaction, including the most severe allergic reaction called anaphylaxis, perhaps to food, insect stings, or any type of medicine. Or if you've had a family history of allergies, or a previous non-systemic reaction, more of a local reaction to a vaccine. Or if you've had a hypersensitivity to anti-inflammatory drugs like ibuprofen, naproxen, aspirin. These people are absolutely fine to go ahead and have the vaccine. And again, if there's any doubt, you can talk about it with your local medical team. So in terms of side effects, for Pfizer, many people get some sort of side effects, but for the vast majority, they will be minor in the grand scheme of things. You may get whole body side effects like tiredness, headaches, muscle aches, chills, fever, joint pain. And this is all normal. And you might recognize these symptoms if you've ever had the flu. And that's because it's a misconception that when you get these symptoms, fever in particular, that's the infection affecting you. Well, actually, it's you fighting the infection. The fever in particular is because your body's internal thermostat, the stuff actually resets higher because the stuff that fights infection works better at a higher temperature. So it makes sense that after a vaccine, when your body thinks it is being infected and it initiates that immune response to the vaccine, thinking it's being infected, you would get the symptoms to a degree as if you were being infected. So it's a good sign in essence that you're getting if you get these symptoms, but it's not hard and fast. So don't worry if you were able to have the jab and you didn't get a side effect. It wouldn't mean that you were having less of a response. You equally might get some local symptoms like pain, tenderness, swelling, redness around where the jab has been received. But it's important to remember, it is, for all intents and purposes, safe. AstraZeneca has very similar side effects. Additionally, you might get from the whole body some nausea as well. And locally, you may get additional itching and you may get some warmth around the site. But again, for all intents and purposes, in the grand scheme of things, it is safe. You may even get more symptoms after the second jab. You've probably heard about that in the media. But again, if you think about it, it makes sense. And it's well documented that that happens. It's because you have already developed an immune response from the first jab. And therefore, when you receive that second jab, the whole point of it is to give a boost to your immune system, really get a more aggressive response to have that added reduction in chance of infection or severe disease. And therefore, you're trying to generate a more aggressive response. So therefore, naturally, you would expect a more symptoms after the second dose. And globally, it's around about 10% for the first dose across vaccines. And around about 22% of people in this country have had more significant side effects with the second dose. Thank you very much.
Thank you, Dr. Mangat, for the information, the knowledge that you just shared. I must say, we has greatly appreciated. Now, there's loads of questions in. So this is where Dr. Steele is going to come on board, but there'll be some questions also going back to you, Dr. Mangat, and Dr. James. So I'm going to identify which question for Dr. Mangat, which question for Dr. Steele, and which question for Dr. James. Is that okay? Dr. Mangat, I know that you said that this is a question from Deslyn Powell. I know you said that it's a virus. However, why is antibiotics not working for this virus?
Thank you. The reason is antibiotics are against bacterial infections, which are different types of infection. And viruses, you might have heard of antivirals, like for shingles, for example. There are antivirals like acyclovir, and there are specific types of medicines against other viruses like HIV, antiretrovirals, because HIV is a retroviral disease. And thus, that's why antibiotics don't work. But there is research going on as we speak in terms of proactive treatments to COVID, as well as research that has already been done and is still going on in terms of vaccines.
Thank you. Dr. Steele, I'll give you a chance to introduce yourself first, then I'm going to start shooting some questions to you.
Thanks a lot. Thanks everyone for having me here. I'm really pleased that I was invited to be able to hopefully share some information and answer some questions. I too am one of the partners at Swanswell Medical Center, and my role today would be more about answering questions and trying to dispel some of the concerns and the myths that are going around that are affecting people's perception as to whether or not they want to take up the vaccine or not. So I wouldn't particularly have a presentation as such, but before you start, as you said, Purcelle, shooting off those questions to me, there was a question that was answered earlier about whether or not we have had our vaccine, and I just wanted to share with everyone. I know the answer was that yes, we all had our vaccination, and that's me there having my vaccine, and that was back in December, and it was really a proud moment. I felt proud. I felt relieved. Although as you know, we might discuss later, it's not the be all and end all. I did also feel a big relief off of my shoulders once I've had that vaccine. And then I also went on to have the second vaccine as well in January. And like Dr. Mangat said, the sort of side effects I had from getting my vaccine were very, very mild. I personally only got a bit of injection site pain, so some pain and tenderness where I got the jab, kind of disturbed my sleep that night, and that was about it. I was perfectly fine after, and in fact, I feel kind of jealous when other people describe to me that they have had more of those symptoms that Dr. Mangat just told us about, those side effects, because I know that this isn't scientific though, but I know that those reactions, those side effects, is simply a manifestation of our immune system doing what it's designed to do. And so certainly we shouldn't be fearful of any of those sort of side effects. So that's just me. So that's me having my vaccination. Dr. Mangat had his, Dr. James had his, and we're all fine. So I'm ready for you, Purcelle. I'm ready for the questions you have.
Okay. Dr. Mangat has just explained to us that antibiotics cannot work on, the virus. Can you explain, according to Debbie Ratty, what is the difference between virus and bacteria?
Well, they're two completely different organisms. They have different structures, different physiologies. They reproduce in completely different ways. They infect us in completely different ways. They're just two completely different organisms, and as a result, the treatments for them are different, as Dr. Mangat explained a bit earlier. Antibiotics target certain structures and machinery within a bacteria, But because those structures and machinery are not present in a virus, an antibiotic simply would have no effect. An antibiotic has no effect whatsoever on a virus. But what you might find happening is that if someone does get COVID, and let's say, for example, develops COVID pneumonia, which is a chest infection, because they are so weakened at that stage, and because the infection is attacking the chest and the lungs, you could have a bacterial infection on top of that, taking advantage of the situation. And so you might then find that doctors and health staff will use antibiotics in the treatment of that patient. And you might wonder, well, why are they using antibiotics? I thought these group of doctors said that antibiotics don't work against COVID. It's because you could have bacterial infections on top of the viral infection, and in which case antibiotics would be very, very useful. Make sense?
Yeah, thank you so much. Now, one of the chief reasons, according to Dr. James' presentation, it said that Black people or people from the BME is the least taking up this vaccine. But according to the same Debbie Ratty, she's stating the vaccine was developed too quick. Can you explain the explanation on that?
You know what, that's a really good question, and it's a really important question. And like Dr. James said, these things should be, these concerns are valid and need to be respected. The vaccine certainly was developed exceptionally quickly. And personally, I'm glad. It's a blessing that we managed to develop it very, very quickly. But there are a number of reasons why it was developed quickly. And Dr. Mangat alluded to some of them, and Dr. James alluded to some of them. If we look at the technology behind the vaccine types that were used for this particular virus, as Dr. Mangat said, that has been in development for over 30 years. So all the way back in 1970s, they started the research and development to try to figure out how can they make vaccines in a safer way, a more efficient way, and a quicker way. But just like any other technology, over that kind of time scale of decades, whether you look at mobile phones or computers, communication technology, things are slow. Things happen very, very slowly over that time period. And we run into hurdles, things slow down. But fortuitously, things happen to allow us to surge ahead and to speed up with the process. And one of the reasons they wanted to figure out something quicker, how can we do these vaccines quicker, is because if we look at the vaccines, the viruses like measles and the vaccines against measles, measles needs to be grown in a lab, in cells, and they need to grow enough of this virus, and then they need to weaken it or take a piece of it or kill it before they make it into a vaccine. And that's really, really complex, and it's really, really complicated. And it took over 10 years, for example, for them to make measles vaccine, to get it to grow successfully in a lab. And so that's one of the things. That's why they wanted to change the way they make these vaccines. And again, going back to something Dr. Mangat said, you had in the past 20 years, 2 big outbreaks of coronaviral infections. You remember he spoke about SARS in 2002, 2003, and then he spoke about MERS, which was about 8 years ago. Those are 2 coronaviral infections, and they were deadly. They were highly infectious, and they posed a huge threat to people. And a lot of research went in at that time to figure out how do we speed up that race to getting vaccines made against those coronaviruses, but not just those coronaviruses, but how do we change the process so that we can deal with any what's now called new and emerging viral threats. And then, bam, coronavirus, COVID-19 hit, SARS-CoV-2 hit, and the technology and the resources were there that had been in development for a very, very long time. And then, Purcelle, there are other things like funding and resources. Governments and non-governmental organizations plowed huge amounts of funding into this because it was such a threat, and funding the acceleration of these programs, the cooperation between governments and universities, pharmaceutical industries like never before helped to speed it up. So those are the reasons the vaccine was developed so quickly, but it has been in development for over 30 years. That's something you cannot lose sight of.
Thank you. Michelle Lal is asking, because the fear, Black people, we fear that it's going to change our DNA. Is that true or false? Can you explain that?
I can see where that came from. Again, looking back at Dr. Mangat's presentation, he's showing genetic material, and he's showing genetic material getting into our bodies, getting into our cells. So you can understand why people would be concerned about that genetic material somehow becoming incorporated into our body, into our cells, and so on. It's a valid fear. But let me just give me 1 second, Purcelle. Let me see if I find something that I could use that might be helpful at explaining my answer to this question. I just try to share my screen. Okay. Right. So by now, we all recognize that. That's the general graphic of the coronavirus infection. And what Dr. Mangat was explaining was that is the spike protein. Now, the reason we're all focusing on the spike protein is because all of that research from SARS in 2002 and MERS in 2012, those big coronaviral outbreaks that happened before, all the research showed us that, hang on, don't focus on any other part of the virus. There's no need to focus on any other part of coronaviruses. If this is the place to tackle, this is the part you need to focus your attention on in terms of developing a suitable vaccine and where to attack the virus. So what do? If they're going to focus on the spike protein, you get the recipe or the blueprint or the instructions on how to make the spike protein. This is the instructions for the whole virus, but we don't need the whole virus. What we need, as was shown to you already, we need the instructions for the spike protein. We need to take a photocopy of that, and that's called messenger RNA. And that is what is then used to inject into our bodies this bit of genetic blueprint, the recipe or instructions, as I like to call it, that's put in a vaccine and injected into our cells. And this is where that concern comes from, as Dr. Mangat showed. Because, Purcelle, isn't that genetic material? Yes,
Yeah.
Isn't this our cell? Yes. So if genetic material is getting into our cells, is it not going to change our DNA? Is it not going to interact with our DNA? The answer is no. It is impossible for that to happen. And the reason it's impossible is because this blue structure here is called the nucleus, and that is where our DNA is stored. And there is no biological way that the mRNA can get into the nucleus where our DNA is stored. And there is no way that our DNA gets out of the nucleus where this genetic material was introduced into our body. And then all that genetic material does, that recipe or that set of instructions, all that does is tell our body to diligently produce all of these spike proteins. And it is that our immune system down here recognizes, memorizes. It's like if you take a mugshot of a criminal and you're showing it to your immune system to learn this face. Do not forget this face. If you encounter this criminal in future, that army that Dr. Mangat spoke about, bring it, because we need to fight this off. Now, those spike proteins, they don't last. The spike proteins that this genetic material produced, those get destroyed, right, by our bodies. And not only do the spike proteins get destroyed, but that genetic material also gets broken down and destroyed from our bodies. And so at the end of it all, there has been no interaction with our immune system, or with our DNA. And the only thing that has happened is that you have our immune system now has been properly trained in order to recognize the virus if it should come into our bodies again. And there you have it. If the virus reappears in our bodies, if we get infected after vaccination, our immune system is able to fight that off. So because of all of that genetic instructions and genetic codes and blueprints getting into our bodies per cell, that is where the concern comes from. But I hope that explanation will demonstrate that doesn't happen. The AstraZeneca one works slightly differently, similar setup, but I wouldn't go through it again because Dr. Mangat did already, but that there's no interaction again. There is absolutely no biological way that there can be an integration of foreign genetic material into us.
This is from Tracy Brown. Tracy Brown. Can the vaccine affect her fertility or even men's fertility? You're muted.
Yes, it just got unmuted. Thanks. If it can affect fertility, is that what you asked, Purcelle?
Yeah. Mm-hmm.
So the quick answer is no. The vaccine doesn't affect our fertility. And I think it was the British Society of Fertility and Reproduction, along with the Association of Reproductive and Clinical Scientists, and I think the Royal College of Obstetricians and Gynecologists, they have all come out and said that there is no plausible way in which the vaccine, they can't even fathom a plausible mechanism by which the vaccine can affect somebody's fertility. It just can't happen.
Okay, thank you. I know Dr. Mangat said there is no animal product in the vaccine. Colin Francis wants to know about the tracking device. Is there any tracking device in the vaccine?
I forgot actually, Purcelle, before I talk about the tracking device, before I answer that question, with regards to fertility, I just wanted to mention that pregnancy, let's talk about pregnancy as part of fertility. If you are trying for a baby, or you're planning on trying for a baby in the near future, then there is no reason not to have the vaccination. You should, when you're called, when you're invited to have the vaccine, you should have the vaccination if you're trying for a baby. If you are pregnant and you are in a group that is at high risk of complications from COVID, you should you should still have your vaccine. If you're pregnant and you are in a high risk group, you should still have the vaccine. If you are pregnant, but you are not in a high risk group, then just wait. Just wait until your pregnancy is over and have your vaccination after pregnancy. So I thought I would have mentioned that, and as you asked me about fertility, I thought I would mention that about pregnancy. Now, as far as the tracking device is concerned, I mean, you have worked in the vaccination clinics.
Yeah.
For those who don't know, we get deliveries, and on average, when the vaccines get delivered, we have to vaccinate on average over a 24 to 48 hour period. We vaccinate over 1,000 patients. 1,000 people get vaccinated over a 24 to 48 hour period once we receive the delivery. And each AstraZeneca bottle contains about 10 or 11 doses, and each Pfizer bottle contains about 5 or 6 doses of vaccine. So Purcelle, if I draw up 10 or 11 doses of vaccine, and I share those out to the paramedics, the pharmacists, the nurses, the doctors, the vaccinators who are working to give these vaccines, if I give you a vaccine out of that bottle, Purcelle, how am I going to know that the microchip, if there was a microchip, which there isn't, but if I injected you with a microchip, how am I going to link that microchip to any database, to make it useful? You know, and if we give over 1,000 vaccines, how am I going to figure out that this dose went to Tom, this one went to Dick, this one went to Harry, and keep track of all of those vaccines when we're working at such speed? But there are easier ways anyway to track us if it was about tracking us. You have our mobile phones, all the location services on your phone that you're constantly using. We have bank cards, we have CCTV cameras with facial recognition, we have CCTV cameras with automatic number plate recognition. It just doesn't make any sense to me at all, Purcelle. And why would one government allow their citizens to be microchipped by a vaccine or microchips made by another government, when those governments may be at odds from a national security perspective? It doesn't make sense. There's no need for it. And if that's your rationale for being worried about having a vaccination, I'd strongly reassure you that there is no such possibility.
Thank you. Rachel Boyce is asking, can you get the COVID disease after having the injections?
Yes, you can. Dr. Mangat pointed out in his presentation the viral efficacy rate, so how good the vaccines are at preventing us from getting COVID. And he clearly showed that it wasn't 100%. There is no vaccine that is 100% effective. So yes, there is a risk of getting COVID, but that risk is small. But more importantly, as he pointed out as well, those who do get COVID after getting the vaccine, those who, let me rephrase that for fear of my words getting misinterpreted. Those who are unfortunate enough for the vaccine not to have worked in them, and for them to have gone on and picked up the COVID infection, those people are at very minimal risk of serious disease, hospital admission, ITU admission, or death. So the vaccine virtually eliminates risk of serious disease and death, even though you might still pick up the infection. I mean, just today, one of somebody I know who's had the vaccine, well, her husband, he had the vaccine, and he's just tested positive. So that's a real life example of somebody I know who has developed COVID after the vaccine. But you know what? He can feel very, very much more relieved that the chances of him getting seriously ill is almost nil.
Thank you. So if someone have been diagnosed with COVID, do they still need to have the vaccine? Lois Ramsey is asking that question.
That's the current recommendation, that you should have the vaccine even though you have had COVID, because although COVID infection naturally induces your immunity, so your body develops antibodies and so on, and that memory is there to fight things off if you should re-encounter an admission. What we are unsure of at the moment is how long that immunity lasts and how good that immunity is. What we do know is those sort of statistics we mentioned of how good things are after the vaccine. So at the moment, we are saying it is safer that yes, you should have the vaccine, even though you've had a COVID infection. But what we're recommending is that you wait 4 weeks from COVID infection before you have the vaccination. Was that what you asked?
Oh yeah, thanks.
Right.
So you're saying, I'm just making sure that Lois Ramsey is happy, that after the COVID vaccination, there's a possibility that you still can have the COVID. So
correct.
The 4 weeks that you're saying, or even further, to still wear your mask, you think there's any need to wear your mask and those stuff?
Okay, so there are a few things you put together in there.
Mm-hmm.
Wait 4 weeks. If you get COVID and you haven't had your vaccine, still get your vaccine, but wait for 4 weeks after having had COVID. And there are probably a few reasons why they're telling you to wait 4 weeks. But just wait 4 weeks, and then if you're called, go and have your vaccination after 4 weeks. The other part of what you in your question there, Purcelle, is whether we need to still wear masks
After the vaccination.
after vaccination. Look at that person I just told you about today. That person had their vaccination and still developed COVID. Going back to what Dr. Mangat said, there is about a 48-hour period before you develop symptoms that you are infectious and you can pass it on to other people. And some people don't even get symptoms. This person who I'm talking about he went to work today, got the lateral flow test done at work, the quick check done, and that test came up positive. He had no symptoms. Then went on to have the PCR sophisticated test and tested positive. So at the moment, that person has no symptoms, but potentially that person is still infectious. That mask, wearing a mask, doesn't just protect yourself. It is meant to protect others as well. So until we get this pandemic under control, the vaccines they don't change things as far as mask wearing is concerned.
Thank you. Debbie Grant is asking, if we take the vaccine and something should happen, who is liable?
I should have bring my lawyer. Well, the thing is, vaccines are very, very, very safe. We have a lot of data spanning decades that vaccines are exceptionally safe. The issues around vaccines, first of all, are short and immediate term problems. And those immediate and short-term problems are usually allergy related, or the worst, more severe form of allergy, which is anaphylaxis. So we have lots and lots of data that that's the problem, that if you're going to get a problem, that might be what you're going to get. And that has been checked in the phase 3 trials that we spoke about earlier, that spanned continents, different countries, northern, southern hemispheres, different ethnicities, different ages. All of those things are safety trials and efficacy trials, and they look out for problems. But not only that, there's still phase 4 surveillance trials that are ongoing, and the purpose of those trials, including in the UK, that's happening, and the purpose of those trials are to identify any longer term issues. And so far, all the data we are having in is that there are no short and medium term or long term problems. And that's just from this bit of information we have. But don't forget, these vaccines are not new as such. They have been in development for 30, 35 years. And all that data shows that they are very safe. But if something does happen, say you came to me to have the vaccine, and I told you about all the pros and cons and the risks and so on, and we take a proper history and we give you the injection, what we do with the Pfizer-BioNTech vaccine, because there were a couple of patients who had severe allergic reactions to that one, we make patients sit and wait for 15 minutes. If I see you have an anaphylactic reaction and we don't have the drugs to treat you, we don't have the oxygen, or I willfully neglect your care, or we don't, some negligence on my part, I am liable if I don't treat you properly. If you come to me for a vaccine and I'm supposed to observe you for 15 minutes and I let you go and I let you drive and you have a reaction in your car and something happens to you or something happens to someone else, I am liable because I did not take the steps that I was supposed to take to ensure that I gave you the vaccine in a safe and proper manner.
Thank you. I'm going to read a question now from Claudia Body and Cheryl. They combine a question together, asking for people who have comorbidities, high blood pressure, diabetes, sickle cell. Would you recommend it safe for them to take the vaccine? 1, and 2, which one of the vaccine would you recommend for them to have?
They should be in the front of the line. They should be fighting everybody else to get to the front of the line to have the vaccine. Because if we can ask Dr. Mangat what his views are and Dr. James, but I'm sure there were slides in their presentations that demonstrated, that looked at those comorbidities. And if you have all of those comorbidities and you are Black and you develop COVID, potentially you may have 1 foot in, 1 foot out, 1 foot in the grave and 1 foot out. So get your vaccine because we know that that vaccine is going to protect you from serious complication. And in terms of what vaccination you should have whatever vaccination is offered to you at the time, at the earliest opportunity, you are offered that vaccination. Next week, we don't know whether we're going to get AstraZeneca or Pfizer. We're going to be notified a few days before, and we're going to get those vaccines delivered into us. And if you're diabetic, hypertensive, obese, or whatever other comorbidities you have, and we call you next week, you should be in the front of the queue, because I hope that Dr. James and Dr. Mangat were able to effectively demonstrate how risky it is to get COVID and have those problems.
Thank you. This is a question from Rayan, representing a class of girls. They are scared of needles. What is your recommendation for them?
Well, lots of people are scared of needles and injections and so on. So it's a valid concern. It is extremely, oh, sorry, my voice is going. But it is extremely under that mask there, I'm actually smiling. You don't feel the needle at all. Most patients are actually surprised, and they ask if, are you finished? Have you done it? Is that all? Is that what people are worried about? Is that what, all these people are fearful of? So the needle actually, it doesn't hurt. It's a quick injection. Like I said, we give over 1,000 vaccines over 24 to 48 hour period. It's quick thing. You don't feel it. And even if you do have that fear of needles, certain things in life you need to overcome. And when you balance the risk, the pros and cons, fear of needles versus getting COVID infections and putting yourself at risk of potential complications, if you were to get COVID and were to develop complications, the amount of needles you would need from intravenous lines and catheters and intubations and so on. Obviously, that's worst case scenario, but for what is a very quick and painless few seconds or couple of seconds, it is way on balance. It is way better to just put those fears behind you. You don't need to look at the needle, just look away. Nobody's asking you to look. We are exceptionally well trained about giving these. We know how to give it in a painless manner. So just have it.
Okay. Coming down almost to the end, I have about 2 questions. This one is more personal towards Rhonda Sims asking, my brother was healthy, gym fit, contracted the disease. Yep, he got out. Now, kidney problems, cannot speak well, cannot even walk well. Can you explain why this happened? If COVID is a lung disease and only affect the lungs, he was intubated.
Purcelle, can I ask Nav to answer, Dr. Mangat to answer that, because he has he has a bit more expertise in that area than I do.
Hiya, thanks very much, Dr. Steele, and thanks very much, Purcelle. Yeah, I mean, you're saying he was intubated. If he was intubated, he was on intensive care. And when you end up on intensive care, you've got a multi-system disorder going there. So that means like not just your lungs, your kidneys, your heart. I mean, sadly, you're in a very difficult situation. And that's part of the problem with coronavirus, with COVID-19, that it can cause significant problems in certain populations. So that's why one of the reasons why he has sadly suffered so much. The kidneys are a major factor, because what happens is that when you get a severe infection, you might have heard of the term sepsis. That's where the infection affects the whole body, and that's the way your body reacts, is to try and shut down supplies of oxygen and blood to other parts of your body, to really try and focus on the core of your body, and often your brain and things. And an early a key feature of sepsis, or severe forms of inflammation in the body, which you might have heard of, the cytokine storm, if you remember that from back in April, those terms, is that the blood supply to your kidneys will shut down, just trying to keep your core body alive. So it starts from your fingers and your toes, and then it just spread, and it moves more centrally, just trying to keep you alive. That's what your body does. More and more things get shut down, and as you might imagine, if the kidneys are deprived of that vital blood supply and oxygen for too long, they will suffer greatly. And sadly, I think that's what I forgot her name, sorry, but sadly I think that's what her brother suffered. In terms of the reaction, after the long COVID is a real entity now. Post-infective syndromes, which just means the long-term effect of an infection, do occur throughout medicine. Pneumonia, for example, you can feel quite clapped out for up to 6 months. The flu, the same. People think they've had the flu, but the flu itself is quite a significant illness, and that's why we take it so seriously each year. And COVID-19 is the same. It can take a long time to recover from on its own, even if you've had it without the severe form that this chap sadly had. And the way I always describe it, it's like a car after a long journey, where you go for a long journey, you switch off the engine, you walk off, but you still hear the fan going. So the car has had that long journey, the engine is off, but the effect of that long journey is still there. The car still needs to cool down its engine and revert back to normal. And that's what your body needs to do after a severe infection. It needs to revert. It's been fighting that infection. It just doesn't go from hardcore fight to the death, let's be honest, to just normal. It takes time for everything to revert back to normal. And like we were talking about, those symptoms, the fever, the chills, the aches and pains, being our body's response to the infection, it takes time for all those symptoms to go away, because they are a proxy essentially for what's going on inside our body. And in terms of intensive care itself has its own problems. And there's something called post-intensive care syndrome. And it sounds like that's exactly what this chap has. And people will have brain fog, people will have difficulty speaking, people have difficulty walking, people have PTSD, something called post-traumatic stress disorder, all very common occurrences after being in intensive care, no matter what the cause. And most people many people will take up to a year to have a recovery, and some people sadly will never quite recover 100%. I hope that answers your question.
Yeah, that's it. My last question, because of time restraint also, back to Dr. Steele. Dr. Steele, do you think, this is a question from M. Rock, do you think that this virus is a hoax? Is it man-made?
A hoax?
Yeah.
Okay. It definitely isn't a hoax. It's an extremely real disease. Yeah, we come out of our houses every day and we walk, take the bus, we drive wherever we're going, we go about our business, shops, work, whatever. and we don't immediately see suffering. We don't see the severe consequences of COVID. But to anybody who thinks that this is a hoax, come, volunteer, come with me. I will take you. We can go volunteer to work on a COVID ward, or the intensive care unit, or the long COVID syndrome clinic, or maybe even accident and emergency. Come and see the real human suffering that is this COVID-19 disease, that is not a hoax. Look at that precious life and all of those precious lives that are being taken away prematurely or being knocked back, perhaps never to achieve their full potential, because as Dr. Mangat just said, you may not ever fully recover. And then tell me it's a hoax. It's not a hoax. And in terms of whether it's man-made or not, all the evidence says that it isn't. I mean, we know that there are all sorts of viruses all over the world affecting animals, plants, humans, all forms of life experience all sorts of types of infections, fungal, bacterial, viral, and you have just teams and armies of scientists whose job is to do surveillance on what we call zoonotic viruses, for example, and just to make sure that none of those viruses that are affecting animals are mutating. And I wouldn't explain what mutating is again, because I'm sure we all know, talking about variants, what mutations are. But they're looking out to make sure that there are no mutations happening in any of those animal viruses that can then make them suddenly able to infect humans. And as this thing took place, all arrows point towards this wet market in Wuhan in China that Dr. Mangat spoke about. That's an animal market. And so the likelihood is that this virus, this coronavirus, was an infection in animals. And like all viruses, they mutate to try to better themselves at our expense. But if it mutated and was able to better itself and jump from animals to humans, that's what happened. And that's what I think, and that's what I think most of the scientific community thinks, is where it came from and not man-made. Of course, I would never know what happens in the highest echelons of government. So I suppose there is a tiny, tiny, tiny risk. I can't say it was definitely not man-made, but I say it's very, very, very unlikely to have been man-made. But anyway, even if it was, we are where we are. We need to do it. We need to protect ourselves. We are all at risk. And being Black and minority ethnic, we are at higher risk. I say to you all, get the vaccine.
Thank you. That's the end of all questions. There was someone who asked if we can email any other information. Yes, I think as River said, that information will be stored on YouTube, so other people could actually take time and go over back this. Well, Dr. Steele, Dr. Mangat, Dr. James, on behalf of the Firstborn International Church, we want to thank you all for taking this time off and giving us such knowledge. We want to thank Mary Quinn, who allowed the doctors to even take time to even present this to us this afternoon, and all the staff of Swanswell Medical Center who have been, firing us and say, come on, you all can do it. And we just wanted, not for a show tonight, but just to offer back to the community as a GP medical center. We wanted to give back to the community. And also as a church, we don't only want to offer spiritual guidance, we wanted to also offer what the scientists also say, and it's up to everyone to decide who is going to take the vaccination. Brother River, it's all back to you.
Thank you, Brother Purcelle. Again, we would like to thank our doctors. Thank you for the information that you have given unto us, and to you guys, we give you a virtual clap. We thank you for your time. We thank you for your energy. We thank you for your research. We as a church, as our bishop has said, it's not our duty to preach for or against the vaccine, but it's our duty to give information about the vaccine, and that's what we've done tonight. And I want to thank you again. Bishop Ferren sends his thanks. Bishop Comrie and the executive board, we want to thank you. To those who would like to forward your questions, if your questions haven't been answered tonight, I'm asking you to send your questions to ifbchq455@yahoo.com, or you can contact myself or Brother Purcelle. That is the end of our session on today on the COVID vaccine and the church. Doctors, thank you. Brother Purcelle, thank you. Everybody, thank you for your participation. May God bless you.